Connection. What does it mean to connect in today's world? And more importantly, how do you effectively connect in today's world? Nowadays, everyone is connected. Our networks are vast. We have thousands of connections, but who are you really connected to? Really? And what does it mean to feel connected? A century and a half ago, everyone knew their doctor. He knew you. He knew your kids. He came over when anyone in your family was sick. He knew everyone in your family and probably knew your grandmother too. He lived in your town. He went to the same places as you did. He spoke the same language as you did, ate the same food. He was the doctor of the town. There was an undeniable connection. That long ago world is almost unrecognizable to what today's patients experience. I recently had to switch my primary care provider to a new doctor, and when asked who was my previous doctor, I couldn't quite remember. What was her name? Was it Dr. Christina or was it Dr. Christine? How about something as consequential as when I gave birth to my daughter? Surely I'd remember the people at my side during this significant life event. Honestly, I cannot quite remember the names of either the midwife or the doctor who helped deliver my baby. After all, I cycled through 10 midwives and 5 doctors during my pregnancy because they weren't sure who would be on call when I gave birth, so I met them all. In healthcare, so much of the work that doctors and nurses and even healthcare staff do for patients has more to do with connection. How did the patient feel? Are they connected with their clinician? Do they trust your clinicians enough to tell you the truth and the whole truth about their bodies, their pain, their lives, and their situation? Because the various clinicians they interact with almost certainly don't really know them. They probably don't know their family, past what they fill out on an intake form. They don't know how the patient eats or exercises, what their job entails, or how they spend their days. So when it comes to providing equitable care for a patient, connection matters. Do your clinicians see the person for their whole self, their cultural influences, their past experiences with the healthcare system? This connection could make all the difference in whether they will answer correctly or even at all the questions your healthcare staff member asks them about whether they are having difficulty getting food each week, or struggles with housing or utilities, if they can't or won't drive or don't have access to a car, or if they are experiencing some type of abuse in their household. Shame and anger are 2 significant forces that can only be overcome by trust, and trust is established only after you first establish a connection. The noted author Brené Brown, one of my personal favorite writers and speakers, says, "I define connection as the energy that exists between people when they feel seen, heard, and valued, when they can give and receive without judgment, and when they derive sustenance and strength from the relationship." That definition is a far cry from posting on your sister's Facebook page, "Miss you, sis," or writing "Congratulations on your new job" on your college friend's LinkedIn post. I get endless notifications saying so-and-so wants to connect on LinkedIn. I suppose connect is the right word. I can't think of anything better, but maybe that's a limit of the English language. It's an association, but not a real connection. So, what can you do to better connect this year? How can you help your clinicians and staff be better at forming connections with patients? Examine your healthcare system organization in the context of connection. Where do you see broken, damaged, or weak connections? Between employees? Between management and staff? Between different locations in your healthcare ecosystem? Where could you grow connections? Between food delivery services, telehealth services, transportation services, and importantly, between nurses and patients, staff and patients, doctors and patients. How can we make our patients feel seen, heard, and valued so they can give, tell your healthcare workers what's really going on, and receive, hear the things your healthcare workers are telling them, so our patients can derive sustenance and strength from the relationship they have with their caretakers? Health equity is about so much more than solving for X in a preset math equation. It's solving for a world of broken and weak connections that make for many invisible problems that surface in very visible ways in our healthcare system. It is those people who take time to invest in you that you feel connected with. Your job is to decide how you will invest in others. Which connections will you nurture and grow this year? What role will you take in the nationwide battle for equitable care for all? How can you make people feel connected, feel seen, feel heard, and feel valued? These aren't easy questions, but we certainly could use some more people out there to bring connection into our healthcare ecosystem. So, in my introduction, as you had listened to, thank you for listening to that introduction.
You're welcome.
That was kind of
Anything.
You really didn't have to.
Anything for you.
I said my word for the year is connection. And for me, there's personal connection. I'm really bad at texting. You've probably realized. I never respond back to text messages ever. I'm really bad.
Yeah, and that's okay. Like I have other friends that don't respond. Like friends that don't respond for months, and I just know now, oh, I'm not going to hear from her.
It's like an anxiety trigger for me. It's very strange. Like when I get a text message, I want to respond in the exact right way. Have you noticed I'm an overanalyzer?
Do you want me to have my sister come the next time so she can do some therapy? Because yeah. So anyway, I'm committed to being a better connector this year. So personally connecting, but then, in the introduction, I talked a lot about what the connections are for the healthcare system. So what we are trying to achieve this year really is related to equitable care. One of the big themes for this year, from a healthcare perspective, is getting people to recognize the differences in our healthcare system that come whenever we're treating people differently. Sure. Yeah.
And so connection, I feel like, is a great word for thinking about how we can make people seen, heard, and valued. And I don't know if you heard that quote from Brene Brown. I mean, that is just such a beautiful quote. To make people feel heard and connected and seen and valued will allow them to establish this trust. And that's really, I think, the first starting place for creating a system, especially when we're talking about the social determinant or social drivers of health measures.
And I think, the difficult part, and we were talking about this a little bit earlier, about like you have to be thinking about things consistently to make a change, right? Yeah. You can't say, well, we're going to connect. You actually have to think as you're going through the motions of your life, what can I do right now to make this connection better?
Yeah.
And that introduction triggered so many thoughts for me about, what we do, how we connect with our clients. And we talk about connection and we think, oh, we're connected, right? Like,
yeah,
we talk, but when we're doing everything digitally, whether it's looking at your quality measure results, your electronic quality measure results, or, messaging with a doctor, are you truly connecting with that person? And how do we connect digitally is a whole conversation that I think is interesting to get into. And then, when you're thinking about health equity, we have to think about that, obviously, from an in-person connection, as we're, as clinicians, as anyone is working with someone who's utilizing the healthcare system. You can't think about it after the fact, right? You have to think about, how can I connect with this person? How can I make their healthcare experience what it should be?
Yeah.
As you're having that interaction, right?
Yeah.
And I think that's probably the most difficult thing to do. I would guess you talk to anyone in healthcare, of course they want to connect with their patients, with their consumers, but actually doing it in the moment, I think, is extremely hard because there's so many other things going on.
I mean, right? Especially with these measures which ask some very difficult and personal questions, like, okay, I could just ask somebody, do you have interpersonal safety issues?
Right.
Like,
No,
I'm fine.
And there may be people that don't even understand that question.
Sure.
Right? And you've got to go to the next level. But you and I have been through the healthcare system for various reasons with our kids, family members, personally. And most of the time, and no offense, meant to the people who are asking the questions, there's so much work to do in healthcare. They're just checking the box. And actually being able to say to someone, hey, I need to ask you these questions.
Yeah.
They're not easy, right? Looking at them in the eye and saying,
I mean, that would make a big
but
difference.
I need, we can help you if you can honestly answer these questions. We can connect you with services, like having more of a conversation about it as opposed to just, okay, I have to ask you some questions, blah, 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 checking the box and moving on.
Eye contact, right?
Yes.
That connection
Yes.
could make a difference. But any way you slice it, those are really challenging conversations to have in an intake form.
Right. Where the person you're talking to isn't feeling good,
Right. They're
is
in the
going
hospital,
through
right.
something that they're not in their normal frame of mind, and they just want to get through the questions themselves. And so we do talk a lot about these questions being asked during intake, also at different stages in their hospitalization. I think maybe that is a great conversation for hospitals to have, for clinicians to have, for the people that are asking these questions to have, like, when is the best time to ask these questions?
Yeah.
Being cognizant that, okay, this patient's pain is managed right now because we've given them pain medications, and I'm going to go back in and have this difficult conversation with them, or potentially difficult conversation with them now. I think the other thing we have to really think about as we dive into health equity is our historical experiences with the healthcare system, right? I know so many people who are dealing with, and I've had this experience myself, with a parent's declining health and being an advocate for them. And I know, not just from my personal experience, sometimes there are things that are lacking in the discharge process where you really need someone to help you, like, find that right service, right? Okay, you're being discharged and you don't have transportation. Let me help you get transportation right now, as opposed to handing you a piece of paper.
And then I have to call somebody.
Right.
And then I have
Call
to
this
figure it
person.
out.
Right.
I know, and it leaves the burden on who?
Right.
Their spouse, the partner,
or the patient who doesn't
or the patient,
have that person to
or,
advocate for them.
Yeah. And I think even you're dealing with those things, sure, but also you're talking about some instances where we're talking about equitable care, people of color who have ingrained generational aversion to the healthcare system.
Right.
And I remember reading an article or listening to something where it said men of color would feel more comfortable in a barbershop talking about their health issues. And so this one group had set up a barbershop to help kind of bring in a clinic and just, do some blood pressures in this barbershop, because it was a safer environment, and they shared way more with their barber than they would ever share with a healthcare professional, which is amazing. But also
we could talk about that for an hour. That's
idea.
Very interesting.
Yeah.
That is very interesting, and I think it's probably a multifaceted issue. What they're used to, like you said, generational, historical, inequities in the healthcare system. And we have to address that one. We have to improve the comfort level, right, of any of those differences in how people of different races, ethnicities, gender, how they're treated, and make them feel comfortable. And that's not easy.
And it requires us to be creative.
Right. And especially when we're talking about the healthcare environment, where someone walks into their doctor's office, they're not feeling good. Someone goes to the emergency, they're not feeling good. All focus is on, let's fix this problem.
Yes.
Let's do the test for flu. Let's set the broken leg and set them up with an orthopedist. And healthcare definitely, as you said in your introduction, has gotten away from that, hey, I'm your physician,
I'm your doctor of the town,
I'm your nurse, but I really care about you, and I want to make sure the whole person is taken care of, And
that's exhausting, because it does come down to everybody's trying to do the right thing,
And one of the things I wanted to talk about this year is, requirements from a regulatory standpoint have really increased for 2023. I wonder if you could kind of just give us a little bit of an overview of like what has changed this year and what hospitals and everyone's going to have to be looking for to.
Yeah, I think the push to digital and digital measurement is happening right now, right?
Yeah.
Like that is absolutely clear in what CMS is doing and what Joint Commission is doing. I think CMS is, to a certain extent, they're pushing the envelope, and I feel like doing things faster than any of us expected.
Yeah.
It felt like for years electronic measures were just, again, kind of that checkbox. We're just going to do it, and CMS didn't change a whole lot of the requirements, or if they did, then they backed off of them right before submission. But now, we're looking at 2024 where there are going to be 3 required electronic clinical quality measures, 2 required hybrid measures, and then we have an outpatient measure that's going to be an OQR measure that's going to be required in 2024, and then those health equity measures, the social drivers of health measures that we're talking about.
Oh, right.
Looking at all of the inequities in health, those things are going to be required in 2024, and actually 2023, the hospital commitment to health equity starts, right? And if you look at the list of requirements and the different tasks and domains within the hospital commitment to health equity, there's a lot of work that hospitals have to do. And I think what they're doing is what we're talking about is not just saying run some reports and submit some numbers. They're saying you have to actually do these actions. You have to incorporate this into your strategic plan.
Yeah.
Your
leadership has to.
Right. And it's all, if you look at that, it's all on leadership, right?
Is it?
It is almost all on the hospital leadership to say, we're talking about this every year in our strategic planning. We have documentation of how we're managing our own health inequities. We're tracking it, and it's more than just the social drivers of health measures. It's hospitals are going to be required to starting now, right, to track where there are other inequities across their health system.
Yeah.
And to be honest, I'm not sure what was in the final rule in regards to auditing of this, but I wouldn't be surprised if those audits come out and it's okay, demonstrate to us, show us where this is in your plan. Show us your reports that show that you're tracking how your Medicare patients are being treated versus a private payer, right?
Yeah.
So I think hospitals absolutely need to be prepared for it, but it's more than just doing this for CMS. I think we're just at a point where we have to do this for the patient populations that we serve and that the hospitals serve. And try to reconnect.
It seems like 2023 really is a prep year.
Yes.
Given, the PC measures are required. That STEMI is an outpatient. There's the opioid, and then there's new ones coming online. It does feel like CMS is giving kind of one more pass year, but this is really it.
Yep.
Hospitals have got to get this stuff up and running in this year if they have any shot, because notably in this month, so by the time this is released, they will probably already have gone out, but CMS is releasing for the very first time results from ECQM submitted in 2022, excuse me. Even though they're not going to be posted on Care Compare, the data is being released.
Right.
And so, what a huge ramification for if you don't, by the start of 2024, capture correctly your PC measures, your cesarean rate could look 50%, and then who's going to...
Right, yeah.
Feel comfortable
and we say it all the time, right? And we obviously know that there's a lot more important things or a lot of other priorities in healthcare, but all of this now serves a purpose, right? And we have to get away from, and I think most hospitals get away from the mindset that we're just doing this because someone is telling us we have to do it.
Yeah.
So much data, the vast majority of data is being captured electronically now, and we owe it, and I keep saying we, like I'm still a nurse in a hospital, but healthcare owes it to their consumers to use that data for improvement.
Agreed.
They really just do. It's not easy though. We hear it all the time. We're reading it in the news all the time about, the nursing shortage and just staffing shortage in general, and so much stress on healthcare facilities right now as a result of COVID, maybe was building before COVID. But that doesn't mean we shouldn't, and hospitals shouldn't start putting plans in place to improve.
Yeah, I'm always struck by the fact that when the regulations are handed down, so many times it comes down to like just a quality leader who's figuring it out on behalf of either their entire healthcare system,
right,
or their individual hospital. And so the people that we work with, a lot of women, they're the ones like leading the charge very silently, and they don't quite get the news headlines like the burnout, but they're the ones that are responsible for getting this all organized.
And they've got to like get all of those stakeholders together too, which isn't easy to do. To pull in the medical staff, the clinicians, the nurses, whoever's doing this documentation, the case managers. A lot of this documentation, I was thinking back to my years in a hospital working, a lot of this documentation is done sometimes by your rehab staff. The physical therapist is seeing a patient.
Sure.
They want to know, like, do you drive? Do you have a car? How do you get around? How are you going to get transportation because you're in a wheelchair now?
Right.
So, it's, and that is so much pressure on those quality leaders. And sometimes not that, definitely quality directors we hear from, but sometimes it's just somebody else working in quality that's been charged with,
figuring it out
here, and maybe brand new to the role. They may be right out of school. They may be transitioning in some way. And so I really think like we are at this point where we have to use the data to improve, and not that implementing the health equity reports and processes are easy, but once you have it implemented, that data should be relatively easy to see where you have gaps, right? Like if you have a report that's showing you, for this type of, for stroke, this is the results we're getting for females versus males on, if they were discharged on the right medication. I mean, that might not be a great example, but it isn't like we're dealing with, did the patient get the right medication at discharge? We're not setting up these massively complex electronic, quality measures. It's, how are your African American populations doing with treatment versus white? It's not as complex once you have the data in front of you.
Yeah, and I think quality leaders, if they could just somehow present what's being burdened to them in a more comprehensive way. I have one slide that we show to some of our quality leaders when we're showing them our software, and it's just the rainbow slide that sort of stacks up these requirements over the years. And every time people are like, oh, that slide right there, that's what they feel.
Right.
Like, it's nice and bright and pretty, but the truth is it feels
overwhelming.
Yeah. Because it just is adding and maybe leaders could come up with a way to display that to their C-suite.
Yeah, and I think as you're saying that, I started thinking we need to make room for all of this, right?
Yeah.
When we talk about connection and improvement, regardless of what we're trying to improve, right? Like I have some goals at home and personally that I want to improve, and I have some goals at work that I want to improve upon. But in order to do all of this, to connect with our patients, to connect with, friends, you have to make space for it. You can't just say it. You can't just say, okay, we have these health equity measures, now go.
Now go ahead.
Right?
Yeah.
There has to be space for it. You have to have meetings where you can have active discussion about it, and not just like, here are the numbers, right? You have to have that active discussion on, look at the numbers.
Yeah.
Let's brainstorm. Let's talk about why that's happening. Do we need additional people in on this conversation? It's making room for that improvement, making room in room, and healthcare means time, and
Yeah.
probably any situation needs time, but making space for that appropriate conversation
Yeah.
with your patient when you're
Yeah.
asking the questions about, do you feel safe at home, right?
Yeah. Yeah, and who has time?
Right.
No one. Yeah.
I
that's
had
so
this
strange.
experience not too long ago. I may have told you about, and I won't go into details, but an experience with my son. I had to take him to the emergency room,
That's right.
and the emergency room was overflowing. My son is 16, and we were in a pediatric ER, and it was the height of all the RSV
Oh,
and
yeah.
flu, and I've never seen this ER so busy. They ended up bringing us back and putting us in a room with another family, which has never happened in the ER there. I've always had a great experience. And some of the questions that they were asking my 16-year-old son were very, very personal. And there was no way they were going to get an honest answer out of him. And he actually started laughing.
I would have too.
Because there he is
That's
with
how
his
it goes.
mother. Like, I shouldn't have even been in the room, let
Yeah.
alone another family.
Right. Wasn't it a 2-year-old too? Like,
Yeah,
it was
a
like-
2-year-old and the 2-year-old's parents, and they were probably mortified.
Oh my gosh.
And I use that as an example because you're never going to get that connection in that environment.
Never.
And in order to have a 16-year-old or anyone answer very personal questions, you have to have the space for it. You have to have that environment. You have to have privacy. You have to and allow that and give them a moment hey, I know this is personal. I know I'm going to ask you some questions that may be uncomfortable, but
Yeah.
I promise you can talk to me about it. And that's the conversation you have with a 16-year-old about, some physical ailments that are personal. The way you handle that shouldn't be any different than the way you handle, hey,
Absolutely.
are you feeling safe at home?
Yeah.
Do you have access to food?
Yeah. I mean,
you know.
human first, right?
Yeah.
Like, even just those 3 sentences, like, I'm going to ask you some personal questions. I know it'll be uncomfortable. You can feel safe to tell me. Like, three statements
Right.
could make all the difference as to
Yeah.
whether I personally answer it correctly. And I know there's, some people, cynics out there will say, well, that's very soft,
Right.
It is. It
But
really
at the
is.
same time, I would gather that most people went into healthcare
Yeah.
because they do have that side of them
Yeah.
that wants to. It was the main reason I went into nursing.
Yeah.
I loved taking care of people,
Yeah.
talking to them, making them feel better. And it's one of the reasons I didn't stay in clinical nursing because
Yeah.
it became very not patient focused. It became all about giving the med and starting the IV and
Yes.
monitoring. And I loved the work I did as a nursing assistant where I was in the room changing the patient, helping them get dressed, helping them
Yeah.
comb their hair. And we have to figure out, obviously we need to patient safety, patient care first. We need to make sure they're taken care of, but we do really, in order to have the most impact on our patients and their health care, we have to reconnect with them. We
Yeah.
have to make them feel safe, feel like they can talk to their clinicians, feel like they can talk to whoever enters the room, and that they're going to be understood.
Yeah.
And there's so much that goes into it. And, I think that most people in healthcare want the opportunity to do that. I think that's why people have left. I think they want the opportunity to connect with their patients, but there's so much other stuff that's required of them. There's such a bigger burden when it comes to keeping up with all the work you have to do, and there isn't space for that often in healthcare, and that's just not fun.
Yeah. We gotta figure it
And
out.
I certainly don't know. I don't know the answers. Easy for me to say. I'm sure everyone will be like, "All right, well, how do we do that?" I don't know, but I think that conversation is definitely worthwhile as hospitals are diving into health equity and starting to look at their numbers and starting to talk about their strategic plan. I think part of that conversation isn't when you're talking about how do we do this, it isn't just like, okay, well, we can make these changes and maybe we document this differently and maybe it needs to be how do we continuously make space for that improvement. That would be my thought. And I don't know the answers, but I think that conversation needs to happen.
That's beautiful. All right, let's wrap it up.
Oh, okay.
So tell us about what's going on this month with our clients' submission time, what's happening, what's going on.
Yeah, it is busy.
It's
This
busy.
is our busiest time of year. We
Yeah.
always say we're in the line of work that we do and that our advisors do. This is kind of like an accountant's calendar.
tax-
You know, this is
tax
our
time.
busy time. But the busy time is getting longer and longer, right? It used to be just a couple of months, but now with hybrid measures on a different submission timeline, and Joint Commission is kind of bouncing their submission
Yes.
timeline.
If you hadn't heard, Joint Commission did extend their deadline.
Yeah, and we
from March 15th to
April.
April 30th.
It's April.
Yeah.
Look at you.
Yeah.
Go ahead.
No, that's all I remember. Keep going.
No, so we are waiting for Joint Commission to open their 2022 submissions. We
Yeah.
finished 2021 end of December because they were, a little bit delayed. We are in the midst of submitting ECQMs for the CMS IQR program right now. That deadline is end of February, so very busy. With that, we're doing education for 2023
Yes.
measures. We're getting ready to activate the 2023 measures in the application, turning on the new measures that have been put out there, and that's all it's just a ton of work.
Yeah.
So the team is working really hard. The hospitals that we support are working really hard. And last but not least, we're getting ready to activate our new Equitable Care
Right.
module in the application in February,
Yes.
which will include not just the new social drivers of health measures and the hospital commitment to health equity measures, which are going to be required by CMS. We are also providing additional reports and stratifications of current ECQMs. So we will have all active ECQMs available to be stratified by payer, gender, race, and ethnicity, which is huge,
Yeah.
and so much data. So we're super, super excited. I've been excited about that since I heard about it, and I'm so glad that we're going to be able to provide that data, because not only will it meet the measures, it will help hospitals track all of the work that needs to be done to meet the HCHE requirements. So they'll be able to look at all of those stratifications and really hopefully start making space for those improvements that need to be done. So
Yeah, a lot going on.
yeah,
Well, I appreciate your time, the conversation.
anytime.
Connection is our word of the year.
And here we are.